Recent advances in surgical arthroscopy include the use of laser technology. Due to specific wavelength characteristics, we have found the HOMIUM-YAG laser to be the most effective of all lasers tested in joint spaces filled with irrigation medium. While the following examples shown are of the human temporomandibular joint, applications can readily be seen to extend to other anatomical areas of surgical interest for the arthroscopic surgeon. We've used the HOMIUM-YAG laser in temporomandibular joint surgery for the past 2 years and have seen benefits including reduced surgical time of ankylosing debridement, minimal postoperative discomfort, and extended ability to perform synovectomy and immunoplasty procedures percutaneously.
In the early 1980s, the carbon dioxide laser was first adapted for use in orthopedic arthroscopic surgeries. A major drawback of this system is that the CO2 wavelength is highly absorbed by water, so that the standard arthroscopic fluid medium must be replaced with a gas medium. This could result in complications such as gas emphysema. The CO2 laser can create carbonization and surface charring, which in turn can induce a reactive synovitis. In the mid-1980s, the HOMIUM-YAG laser was developed. It operates at a mid-infrared wavelength and can be transmitted fiber optically, which suits it well for arthroscopic surgical uses. Holmium is a rare earth element that, when doped into a YAG crystal and is stimulated, emits energy at 2.1 micron wavelength. It is well absorbed by water and easily transmitted through quartz fibers. A flash lamp acts as the energy source to the laser medium. This family of pulsed lasers has power that ranges from 15 to 60 watts of average power and pulses of 5 to 40 times per second. Pulse energies can be between 0.5 to 3 joules per pulse. The HOMIUM-YAG laser can be used in contact or near contact mode and works well in any standard arthroscopic fluid medium. It generates enough thermal effect for hemostatic capabilities without charring or carbonization of the adjacent tissues. The HOMIUM-YAG laser beam is highly absorbed by tissue water, creating heat that boils the cellular fluid. This results in ablation, cutting, or vaporization of that tissue. There are some precautions required for the safe use of the laser. The patient's eyes should be covered with 2x2 saline-moistened pads that are stabilized with tape. Eyelids are very thin and do not provide sufficient protection to the eye from a stray or reflected beam. To help create a laser-safe environment, all doors entering the treatment area are marked with warning signs indicating the type of laser in use and the maximum output. The surgical team working within the nominal hazard zone should wear appropriate protective eyewear for the laser being used. In many hospitals, a laser safety officer has been appointed and a laser safety team organized, establishing the foundation for the development of safety policies. These policies address eye protection and fire hazards. Review these policies prior to any laser procedure. The patient's face and neck are thoroughly prepped with betadine solution. Next, the surgical areas are draped with plastic towel drapes to give maximum access to the surgical site while at the same time creating a water-repellent area. Then, surgical drapes are applied. Due to the high flow of irrigation medium, fluid collection bags are advised. These may be made by modifying cystoscopy or shoulder arthroscopic bags. If long procedures are anticipated, a vacuum-assisted fluid collection cannula can be utilized. Individual fluid collection bags may be applied to both sides for bilateral TMJ arthroscopic surgical procedures. With draping complete, the surgical assistant can manipulate the mandible through the drapes while maintaining the sterile environment. Ear packs are then placed to protect the external auditory canal from excessive blood or debris. The laser probe, made by Coherent, emits energy pulses through a 400-micron quartz fiber. The fiber should be protected upon exit from the laser to prevent kinking or torquing at this connection. Extreme care and precaution must be taken to prevent fluid or finger oils from touching the SMA connection on the fiber, for this could necessitate a minor servicing of the laser. The lactated ringer solution, with 1,000 IU of heparin per liter, has been cooled and placed into a continuous pressure bag. This is attached to the inflow of the arthroscopic cannula. The laser probe, which is approximately 8 inches in length and connected to a fiber optic cable which attaches to the laser. It is a good technique to protect the tip of this delivery probe, even though the laser is placed in standby when not in use. The fluid collection is shown here, with the vacuum-assisted area, the anterior portal, a fluid retention rubberized stopper, and a continuous flow exiting the superior anterior cannula around the probe. In the superior joint compartment, with the arthroscopically placed laser probe, an anterior release procedure can be accomplished. Next, a review of the triangulation placement of this anterior portal. A percutaneous transillumination and parallel vector guidance system is employed. This allows for direct and quick access for triangulation. The cannulas are of equal length and are placed parallel to each other along the lateral region. Then the anterior cannula with the trocar is raised perpendicularly to the arthroscopic cannula and entrance to the superior joint compartment is accomplished. The inflow is connected without the outflow at this point to distend the superior joint compartment. The blunt trocar is then placed into the cannula and further entry into the superior joint compartment is accomplished through the capsular wall. A lateral eminentia release and capsular stretch procedure is then completed from the posterior superior lateral portal or the anterior superior portal. This allows for greater mobility of the surgical instrumentation during triangulation with a laser probe. Note that this lateral eminentia release and capsular stretch is a surgical procedure with dissection in the subperiosteal plane up over the lateral tubercle of the eminentia. This is an actual surgical release of the fibers of the temporomandibular joint ligament from the articular root of the zygoma, allowing reattachment at a lower level. A rubber stopper is then placed to help prevent excessive loss of fluid and to create a small amount of back pressure in the joint. This helps to keep it distended. It is advisable to use a valved cannula for this part of the procedure to aid in controlling the back pressure of the fluid. The laser probe is placed into the arthroscopic cannula with triangulation accomplished in the routine fashion. Continuous flow from the pressurized bag of heparinized lactated Ringer's solution aids in flushing the debris and cooling the joint during the laser-assisted arthroscopic procedure. The quartz fiber of the laser probe is clearly illustrated by the helium-neon aiming beam. It is an excellent tool to ablate and debride a joint with fibrous adhesions and ankylosis. In this case, it is used in a contact as well as near-contact mode. The tissue in line of the laser beam is being vaporized, and the field is being cleared efficiently of adhesions. Since the holmium-YAG laser energy is invisible, the red targeting beam from the helium-neon laser is being used for aiming. The holmium-YAG laser has a short absorption length, which gives more precision and produces minimal deep tissue heating. In reality, there is no extension of the thermal effect beyond 1 millimeter of the visual cut. The depth of the thermal necrosis is limited to within 50 microns, and thermal change can extend to approximately 400 microns, or 0.4 of a millimeter. The constant irrigation into the joint cavity is essential to dissipate any heat that is generated by the laser beam. Attention should be paid to the outflow portal to make sure fluid exits the joint. This will avoid an extravasation of irrigating fluid into the adjacent tissues. Using the laser to debride joints with fibrous ankylosis has been found to be extremely efficient when compared to mechanical debridement with either a meniscal cutter or arthroscopic grasper. Occasional debris which is too large to be flushed out the exit portal must be grasped by the forceps and taken out. A 40% to 60% reduction in operating time, however, can easily be realized on these ankylosis cases when utilizing the holmium-YAG as opposed to the motorized debridement. This is an obvious benefit for both the surgeon and patient in reduced trauma of surgery and results in an increased healing response. The graspers are being applied to take out the debris of the ankylotic and fibrous tissue. Next, an anterior capsular release is performed on this left temporomandibular joint in order to increase mobility of the anteriorly displaced disc with morphologic distortion and obstruction, as well as adhesive capsulitis and lateral fibrosis. The arthroscopically placed laser probe is being positioned into the anterior synovial space. The anterior recess is located and the release is begun from the medial aspect of the anterior superior synovial pouch, moving laterally. As the synovium and capsule are cut with a laser, they separate very nicely. The laser tip itself can be used as a probe to a limited extent to help separate the fibers of the capsule and of the pterygoid muscle when encountered. A rationale for the use of the anterior capsular release is found in the phenomenon of morphological disc blockade. Sometimes with anterior or anterior medial disc displacement, condylar rotation is allowed, but with minimal translation. A phenomenon known as discal blockade occurs. As the histomorphics of the discal tissues become altered with shear forces on it, some discs become deformed to the extent that the condyle can no longer negotiate a translatory movement. Anatomically, several events can occur. 1. A physical blockade of the condylar translation by the deformed disc itself. And 2. Limitation occurring due to the confinement of the anterior recess by the superior joint space and its attachments. The benefits of this anterior capsular release are also twofold. 1. Liberating the disc, creating an essence of functional discectomy, and 2. Physically enlarging the superior joint compartment to allow greater translatory space with the disc moved further forward. The anterior capsular release is actually performed by creating a laser incision from medial to lateral in the anterior recess to the point of visualization of the lateral pterygoid muscle fibers. Here, the lateral pterygoid muscle fibers are being exposed. Some of these fibers are actually incised at the same time. This newfound freedom of movement is immediately realized. The release is completed when the muscle fibers of the lateral pterygoid muscle are exposed from medial to lateral. After the release, any obstructions of the disc and condylar glide should be checked by manipulating the jaw in a forward and backward motion.
To summarize, the homeomyag laser combined with arthroscopic technique offers the oral and maxillofacial surgeon a greater advantage to the surgical approach to the temporomandibular joint. It offers the potential of more rapid and less traumatic healing to the patient, as well as a reduction in the time of surgical manipulation.